Good morning. It's my pleasure to introduce Dr. Marie Steiner for Grand Rounds this morning at Lab Medicine. Dr. Steiner seems to be a dyed-in-the-wool Minnesotan. She got her undergraduate degree at St. Olaf in biology and music, which is an interesting side note I didn't know. She then came to the Twin Cities, where she got her master's and her MD at the University of Minnesota. She went on to do residency and fellowships in pediatrics, hem-onc, and critical care. So she's reasonably well-trained. And after completing her training, she went to West Virginia for a few years, but then returned to the Twin Cities, where she has been ever since, and we're very lucky to have her. She has won numerous awards. She is well-funded. She runs clinical trials. She is one of these triple threats that we always want to be. She was named top doctor by Minneapolis-St. Paul magazine over 5 different years, and in the off years, when she wasn't a top doctor in that magazine, she was named the best doctor in America. So I think she's doing pretty well. Today she's going to talk to us about a major clinical trial that was huge in the transfusion community, looking at the age of blood. It's entitled the Red Cell Storage Duration Study, RECESS. Marie, thank you.
Thanks, Claudia. I'm a little embarrassed by all of that, but I am also, I was also a cheerleader at St. Olaf, which is probably why we got RECESS done. I have to tell you that RECESS represents an enormous contribution of all sorts of effort, angst, sweat by many of the people in this room, by many, many people nationwide, to the 2,000 or so patients who were involved. And credit has to go where credit is due. The name RECESS was developed by Jeff McCullough. And so I think we had a bottle of champagne. Maybe I still owe you, but at least that's one more tie to Minnesota. All right, conflicts of interest. The folks that were listed on the first slide declare that they have these. This was the Protocol Leadership Committee. Now, lest you think that this is just something we made up in our garage overnight, note that it took almost 9 years from start to completion for RECESS, about three times the gestational length of the Alpine salamander, which is the longest gestation in the world. So when youngsters come to you and say, I'd love to do clinical research, make sure they have another way to support themselves. I do critical care, and so no one bugged me about how long it took me to get stuff done. The major question we're asking when we ask issues about red cell storage is, does controlled aging alter quality? You may disagree about some of these aged processes, but I happen to love share. So by way of background, we all know, you guys all know, that red cell licensure is based on survival, not function. And the reason we give red cells is to increase oxygen delivery. And since we can't really control oxygen consumption with just a transfusion, this is our surrogate for optimizing oxygen consumption at the cellular level. And the goal is to lessen organ or tissue ischemia and to hasten medical and post-operative recovery. Well, does this really happen? And the question is begged by all the swirling in the scientific community. There might be limited efficacy of red cell transfusions to restore oxygen carrying capacity. We think longer red cell storage may be associated with different sorts of changes to the function, the structure, the characteristics of the red cell. They don't all wind up looking like Sean Connery. And transfusion may actually compromise survival. So people have put all this together and called it the red cell storage lesion. And as red cells are stored in the blood bank, outside the body, they undergo a series of changes: biochemical, metabolic, structural, inflammatory, and physiologic. And this is put together in a diagram by Phil Spinella back in 2007, which diagrammatically shows you that all these things probably impact microvascular perfusion, oxygen consumption, development of multiple organ failure, and potentially death. could ensue. To show you that there's equipoise still, Phil and I are good friends, and we are on 180 degrees apart on whether or not stored blood has any detrimental impacts. But we're not alone. There have been many major studies looking at whether or not storage age of the red cell product affects outcome. Outcomes measured are myriad, populations are numerous, circumstances are numerous, and there are many major studies which also mixed results, which people summarize every few years. Most of these trials are retrospective, observational, and there are a few randomized trials. In particular, most of the studies in cardiac surgery patients have been retrospective to date, and some of these studies found significant adverse outcomes in those transfused with red cells that were stored for longer periods of time versus shorter periods of time. Now, Recess undertook to address that question. At the time, the network that was working on Recess, the Transfusion Medicine and Hemostasis Clinical Trials Network, felt pushed by the study Colleen Koch had published just a short time earlier to do the definitive study. So credit to Jeff and to Paul Ness for pushing us from a physiology study to an actual outcome study like this. The primary hypothesis to Recess was that there would be an important difference between the effect of shorter storage red cells versus longer storage cells on the clinical outcomes in the cardiac surgery population. The design of the study you see here, patients were consented preoperatively, randomized to receive either shorter or longer storage aged red cells prior to their surgery, in their surgery and through their surgery. Our primary endpoints were measured at day 7 and day 28. The outcomes that we were measuring at day 7 and day 28 were, first of all, the change in multiple organ dysfunction score, or delta MODS, from preoperatively to the highest composite MODS through post-op day 7, death or discharge, whichever came first. So the MODS score was the composite, the worst score, accrued through that 7-day window, which we'll talk about a little more in a second. Our secondary outcomes were day 28 delta MODS, day 28 mortality, and the occurrence of serious adverse events. Now the MODS score was something that we decided we needed to use. Its developer, John Marshall from Canada, who was an intensivist, developed this score in 1995 and was actually a consultant in the early phases of the study development. Mortality is a pretty gross outcome, but something that's attainable as an endpoint if it occurs readily. In cardiac surgery, even in the worst of the worst, mortality is only 6, 8, 10%. And so to do a study based on mortality as a primary endpoint would require thousands and thousands and thousands of patients and many, I think we figured out $22 million in budget. So we decided to use something that was as sensitive as we could possibly make it to hopefully find out if there was even a signal if red cell age impacted surgical outcomes. And so the MODS score is a sequential score based on these organ systems, which may or may not have dysfunction evident at different periods of time post-operatively. We know they do in cardiac surgery. The lungs go first, the liver goes last. And so the MODS score is a score for various increasing degrees of dysfunction for lung, kidney, liver, cardiac, heme, and neurologic systems. It's a correlate of mortality. In the ICU, you can see the scores increase with mortality. And in terms of hospital mortality, the scores also increase as a correlate of mortality. So we capture mortality. But we also capture all the subtle changes in organ dysfunction that could potentially lead up to it. So we use MODS again because the data elements are objective. A lot of studies use outcome measures or organ dysfunction measures which involve modifications of inotrope use, ventilator management, transfusion triggers, and you just can't get people to do that across the board. It incorporates, as I said, organ dysfunction and not just failure. It correlates with mortality and length of stay, and it incorporates death. So we do capture death within our spectrum. It's also widely used in adult ICU and surgical populations, and it was actually used in the TRIC trial by Paulie Baer to look at his populations, again recognizing that death probably isn't that common. To calculate the 7-day change in MODS, for each of the organ systems, we identified the worst score through day 7. So it's a composite of the different worst scores, discharge or death. The maximum score for each of those days was tabulated, and the 7-day MOD score is the sum of the worst score for each organ system across that 7-day window. And the delta MODS, the change in MODS, was what was the pre-op status to adjust for the baseline for the 7-day change. Now, interestingly, our preoperative MODS was quite low, 0.6, 0.7. So most of these people were coming in pretty good shape, in contrast to the ABLE study, which we'll look at in a second. The analysis was a modified intention to treat, meaning only transfused patients were analyzed, because if you're looking at the effective transfusion, how can you look at somebody who wasn't transfused? And what we were looking for is the precision of a two-sided 95% confidence interval for the treatment group difference being a little bit less than 1 MODS point or narrower, suggesting that really there just is not a difference in even subtle organ dysfunction across a multiplicity of organ systems with red cell transfusion. We wanted to make our endpoint as sensitive as we could to pick up any sort of signal that the red cells were doing something to the patient physiology. The patients we included were over 12 years of age. We talked with John Marshall. We looked at perfusion setups and characteristics and volumes of distribution, and decided over 12 years old, greater or over 40 kilos was a pretty homogeneous group in terms of their baseline demographics. They would have to undergo a complex primary procedure with a median sternotomy planned, or a redo cardiac surgery, going back to the work of George Despotis, looking at which patients are most likely to be transfused. You don't want to do a lot of fetal consenting, a lot of fetal setup, and a lot of fetal blood bank management. About the time we were setting up recess, the VA published a big study saying on-pump or off-pump operations had not much change in their outcomes. We really didn't have very many off-pump patients, so it really didn't matter in terms of the ultimate analysis. And then we used a tool called the TRUST score to find patients who were likely to be transfused intraoperatively or within 96 hours post-op. The TRUST score was, as you see down below, the Transfusion Requirement Understanding Scoring Tool. Everybody loves acronyms. Published and validated by the Canadians to identify folks who are in their hands back then, and we'll go back to that in a second too, 10 years ago, 80 to 85% likely to receive a transfusion if their various parameters exceeded 3. Very simple thing to use, don't really have to incorporate a lot of time or a lot of laboratory study preoperatively. Age, gender, baseline hemoglobin, weight, baseline creatinine, surgery's elective or not, they've had surgery previously or not, and the surgical tasks are isolated or multiple. So anybody with a score of 4 or more was likely to be transfused. We validated this in our own surgical populations at several of the big centers, and so that was an inclusion criteria for people over 18. This has not been validated in kids over, in children or anybody less than 18, but we had so few between 12 and 18 in recess that we can't do that for them. Exclusion criteria you see here, we excluded folks who were setups to have horrible post-operative courses right up front, like intra-aortic balloon pumps. Folks who are refusing blood products, makes no sense to enroll them. Folks who have unusual requirements, it's hard to know what you're doing to the product if you're washing it or spinning it. And then anybody who wasn't going to have a typical type of bypass management, so heparin alternatives and things of that sort. So, folks were randomized between red cells stored less than 10 days or greater than or equal to 21 days, and they were supposed to get red cells of their assigned age for all of their transfusions from randomization through day 28 discharge or death. Most of the transfusions are given within the first 4 days. Elliot Bennett Guerrero showed that, and so we figured we would be good going through the first month. Randomization details included stratification details, as you see there. And then this was an enormous issue. Recess wound up being partially blinded in that the clinical staff and the research nurse were not told the study arm, but the expiration date on the red cell bag was not obscured. We had several meetings with the FDA, and they wanted it covered. They wanted it tamper evident, so if anybody was devious enough to peek, that we'd be able to see. And it had to be non-defacing so that if the product wasn't used, it could go back to the blood bank and wouldn't interfere with inventory supply. But if they did all that, then they also wanted to rewrite the protocol, and we said, that's okay, because we did a little test of 65 colleagues, gave them different pictures of blood bags, and said, how old is this? And, and only one person in all of those people, and they were ICU docs, nurses, fellows. The only person who got the test right, and there were 6 different bags, any of them right, was Marissa Tucci from Saint Justine, who's running the pediatric trial now. Nobody else could get it right. So we felt pretty comfortable that it was okay to not obscure the label. Interestingly, the pediatric study that's ongoing does have obscured labels, and it's quite a headache to get it through, but it has been, we've all learned. So anyway, moving on. The next thing that came up was inventory management was a challenge. So we had sites take a look at whether or not they would have enough inventory in the less than or equal to 10 day and greater than or equal to 21 days in order to randomize patients. That's the point at which the OHRP got involved after we'd randomized one patient and said, oh, no. You can't age blood. We don't think it's going to wind up like Sean. You can maintain a study inventory of fresh units, and you can call in fresh units, but you cannot purposefully maintain an inventory of older units. So much for equipoise. But the compromise then was, and this wound up putting the study on hiatus for 3 months, but I think it wound up being a better study because the patients could be randomized within 24 hours of surgery only if they had sufficient units of both age groups available. And sufficient means enough to match the cross-match, meet the cross-match. So if you were going to be randomized, you could be randomized if you could get in units less than or equal to 10 days, or if you happen to have that would be administered to the patient with the local policy of first in, first out, if those units would be over 21 days of age. Turned out this made it much more easy to consent the patients because they were told you will get what we've got in the blood bank now, which is our usual policy, or you're going to get less than or equal to 10 days, and we don't know which is better. So it made it much easier to consent than to say we were purposefully aging blood. The characteristics of the unit I included because I thought folks might be interested. All cells were pre-storage leukoreduced. It's interesting, and there still are centers at this time we started this, still places in the U.S. that don't pre-storage leukoreduce. We decided on these particular additive solutions. Able used different solutions for preservation. Irradiation was discouraged, but if it was done, we asked centers to irradiate shortly before issue, so that issues with potassium, for example, weren't a problem. Did not include washed or deglycerolized units, which took us out of a lot of it because our perfusionists insisted even back then on washing, as did some centers. No volume reduced units, again because we're worried about the shear stress and what that does. And then administration, despite what the FDA wanted us to do in terms of establishing when you would give red cells, I don't think I have the expertise to tell a cardiac surgeon when he should or should not transfuse a 72-year-old. I'm a pediatrician. So we all agreed on administration according to local practice as ordered by the clinical service, and we did not establish any hemoglobin or hematocrit triggers. Those numbers, I would submit to you, still don't really exist in this population. So, in terms of the patients in recess, we consented 1,709. We attempted randomization in 1,613. There were some that were consented and they weren't going to have their operations. They were going to have the wrong operation. Something came up in the meantime, and so we didn't try to randomize them. Of those randomized, of those attempted, 1,481 were randomized, and it's interesting in that as we continued through the process, we were able to see that although there were some centers who couldn't get fresh cells, young cells, short storage cells, the greater majority of those folks who were not randomized were at centers who didn't have an inventory that they happened to have 21 days or later. So there's probably a shift toward leaner, and you guys probably know this better than I do, leaner inventory management, so stuff gets used up sooner and there's less hanging on to the later ages of storage permissibility. Of those folks then randomized, you can see a nice equal randomization to less than 10 and greater than 21. And the evaluable subjects, again, looked like we did the data in the bathroom. If they're randomized and not evaluable, they either didn't get transfused, had a different operation that was planned, so it didn't meet our criteria. Some died in the day between randomization and surgery. Unfortunately, 3 people did in each arm. And so we wound up with a fairly even population of evaluable subjects. Part of the reason also, we'll talk about it here, some of them weren't evaluable, is they didn't get transfused. We selected a population that we thought would be transfused by virtue of their trust score, and we missed the mark by 8-9%. Even in that 9-year window, transfusion avoidance was already creeping into practice. And so we wound up only transfusing 80% of the people we would have predicted to transfuse instead of 85 to 90%. So it's a good thing we didn't take longer. Now, the subject and the procedure characteristics you see are very similar in both arms: ages, gender, bypass, coronary bypass only, and remember that would have to be a multiple bypass, not a single vessel repair. Valve repair only, that would have to be a redo if it were a single procedure, and then all the other procedures, which would either be multiple initial or redo. Again, the people who worked on this study just did an amazing job. These are the number of units transfused per subject. The number of units per subject by study arm were not statistically significantly different. The fresher blood is in the dotted black line, and the 21-day or older product is in the red line. And you can see the number of units transfused and the percentage of patients who got that number of units looks virtually superimposable. The storage duration of the red cell units, there was excellent compliance with the randomization assignment. You see the short storage age in black, the longer storage age in red. You see the wide distribution of age at the longer end of the storage duration, and you see that there's very little crossover, and it's similar in both arms. You have very few units, 88 and 136 out of thousands in the black arm or the short storage age that were outside of that less than or equal to 10-day window. And you have 50 and 126 that were younger if folks were assigned to the longer storage aged window. So again, very, very good separation. Compliance on a per subject basis was also excellent. We had 87 and 89% of folks with all their red cells unit in the assigned age, which is just amazing ability on the part of the folks in the blood bank to be able to maintain inventory, to be able to honor the ARM assignment. A few, as we saw on the last slide, a few folks got units that were in the intervening range, and only a few folks got more than one or more unit from the other ARM assignment. So again, very, very clean separation. Now, the punchline, the outcome. When it comes to looking at the delta composite mods, which was the most sensitive parameter we could identify to be able to tell what these folks looked like in terms of their clinical outcome if they got short versus long storage age. You see here the folks that received blood less than 10 days or greater than 21 days, their 7-day delta mods was only different by 0.2 points to the benefit of the less than 10-day. And the adjusted difference, if you took into account what their baseline mods was no different. So virtually indistinguishable, not even close to statistically significant. Similarly, at 28 days, the folks who received the shorter storage age had a mods of 8.7 plus or minus 4, and the folks at 21 days had 0.4 points more, plus or minus 4.2, so the unadjusted difference is 0.3 to the better of the short storage, and adjusted difference is very tight as well. So, no clinical difference. If you look at between group differences in all these things that we up front said we would look at, which included blood group and male, female, and age and race and kind of surgery and ICU at randomization and trust score and whether or not they were heavily transfused, so greater than 8 or lower than 8 red cell units administered, nothing is significant except the folks who didn't designate their race. Okay, that makes no physiologic sense. And then folks who were group AB showed a trend toward having a better clinical outcome if they got the older storage age product, which is, I can't make sense of. So none of these between group differences were significant except if you didn't tell them what race you belonged to and if you were an AB. All-cause mortality was not statistically significantly different either. Here's the cumulative percentage of patients who died. Here's the time since the date of procedure. You see out to day 28 that there was no difference statistical in the time to death. The 7-day mortality was 2.8% and 2%, and the 28-day mortality between arms was 4.4 and 5.3. So not statistically significantly different. Interestingly, when we powered the study and figured out our study numbers, we were looking for a mortality comparable to the published mortality of 6 to 8% for this population, and our mortality was lower than that. So again, people are getting better and better at what they do, and probably good that we didn't delay doing the study any longer than we did. Serious adverse events, the secondary outcome, showed no significant difference in the number of events and number of subjects with more than one serious adverse event and the number of serious adverse events per subject. So just no signal, cannot find a signal that shorter is better than longer. So that was indeed our conclusion. The transfusion of cells stored less than or equal to 10 days compared to those stored greater than or equal to 21 days to folks undergoing complex cardiac surgery didn't result in difference in clinical outcomes. Key to the patient, their 7-day delta mods, again, a very sensitive we were really, really looking for a difference and didn't even find a difference in the 7-day delta composite mods, the 28-day delta composite mods, 28-day mortality, or serious adverse events. Again, I'm honored and humbled to be able to present this information, but it represents work from all these active sites. Here you see our group and the folks without whom, I'm a neophyte at this. But with Jeff and Mary and Shelley, everybody in the blood bank, and don't forget our colleagues in cardiac surgery, we were able to get recess done. There goes my water, which I will need. Now, lessons learned. Because this did take 9 years, it would take me probably 9 years to walk the Great Wall, or maybe a mile or two even. Having been there, it's really high up. I think the things we learned include the fact that all great achievements take time. Whether you will vote for her or not, it does take a village. And something my daughter said when I gave her a list of tasks, which would thereby clean her room. That was before we took her to speech therapy. I think this is real important when you're directing your research team. They're not your Cinderella. They are your colleagues. They are your compatriots. Without research coordinators and blood bank technicians and bedside nurses, you are not going to get this done. So those are the things we learned. Now, you never let an opportunity go by without exploiting it. So there are 2 coordinated research projects that were done in association with recess. One is completed and submitted, that's RECAP, and one is undergoing evaluation right now because it had late follow-up that they were trying to tabulate. RECAP is trying to get at the question, do red cells that are banked actually change oxygen delivery and oxygen consumption? And do they change microvascular perfusion? So RECAP was designed, RECAP was designed to look at peripheral tissue and cerebral oxygenation with near-infrared spectroscopy, using the thumb as a skeletal muscle measure. If you really don't have good oxygen delivery, your thumb ought to suffer. The brain, if you don't have good oxygen delivery, your brain is the one we don't want to suffer. And then microcirculatory perfusion with SDF. You put the little probe under the tongue and you measure video clips of little red cells going through the vessels underneath the tongue, how fast they go, how dense the capillary bed is in a particular surface area. This can be done under the tongue in adults and in children who won't bite the probe, and actually can be done under the armpit in preemies. So it's a tool that I think is a lot of fun, and we used all 3 methods to look at our recess subset at folks preoperatively before any red cells and even before their operation, postoperatively just before we gave them a red cell transfusion, 1 hour after a red cell transfusion post-op, and then 24 hours roughly after that transfusion, to look at all these parameters to see if giving red cells less than 10 or greater than 21 changed tissue saturations, flow, and vessel capacity. It's been submitted, and hopefully we'll hear soon. The results are very interesting. Then the military was very interested in whether or not old versus younger product is detrimental to their vets. And so the recess mechanism and repository was set up to look at laboratory measures addressing these features, to serially characterize the recess patients in terms of these parameters at these days, and then to create a repository of the product left over for people who might want to look at things later. Now, in the same New England Journal of Medicine issue as recess, the article immediately preceding recess was ABLE, which is if you will, the companion study done in the Canadian Clinical Trials Group, looking at age of blood in adult critical care patients. So not cardiac surgery patients, but adult critical care patients. And this is a slide I got from Jacques because I'm just not very good at graphics. The ABLE design was very similar to recess, and it's interesting that these things were being developed in parallel. Eligible patients would be randomized to the experimental group, which he called FRESH, which they wanted less than 8 days, or the control group, which was usual transfusion strategy, which could be anything from 2 to 42 days. We have had multiple discussions, some friendly, some with wine, some not so friendly, over whether or not recess was even ethical. In some people's minds, it was not ethical to give people the older product, except if it is standard issue in your hospital, that's what they get. So anyway, we'll never agree. But they also used less than 8 because they thought 10 was already old. So less than 8 and up to 42 days, the outcome in the ICU population was 90-day mortality because their mortality rate is much higher than it is in cardiac surgery patients. So their study was a double-blind, multi-center, randomized controlled trial, 25 Canadian sites and a number of European sites in the UK, France, Netherlands, and they actually added Israel toward the end. 60-odd centers ultimately, looking at adult ICU patients with the objective being to compare the effect of transfusing the cells less than 8 days to standard issue on morbidity and mortality. Their patient characteristics are indeed a little bit different from recess patient characteristics. The age is similar and the gender distribution is similar. The length of ICU stay is not too dissimilar, but their multiple organ dysfunction score was much higher than recess entry. So they're looking at a MOD score of between 4.5 and 5.5, even up to 8, whereas our patients were 0.6 and 0.7. So sicker population going in, and that makes sense. They're medical patients coming into the ICU. Most of them were medical admissions. Less than 20% were trauma, and only a smattering of surgical. The red cell storage duration also got a reasonable separation between most of the transfusions. These are their short storage age cells in black, and this is the distribution of their longer storage age cells in the gray bars here. So again, reasonably good separation. There is some overlap, and there always will be because we just can't predict what everybody's going to need. Their transfusion characteristics were similar in terms of the number of red cell units folks received, but what was different is that they had more trouble getting folks who got fresh blood. I don't know enough about the Canadian blood banking system to know if that's expected or not, but they, obviously standard issue is going to be 100%, but they had more difficulty getting folks their shorter storage length blood. Primary outcome. This is not at all what he expected. Not at all. The primary outcome, death by day 90, no difference. 37% in the short storage arm and 35% in the standard arm. So no difference. Looking at their secondary outcomes, no difference in any of these either. Their additional secondary outcomes you see here, just like you saw with us, their MODS highest score started out here. Delta was 1.4. So they went in sick, they stayed sick. Supportive care duration is here. Fresh blood, standard blood, nothing significant. So their conclusion was that there's no evidence that the critically ill adult ICU patients are going to benefit from fresher red cells when transfused. Now, there are still ongoing trials, and we're participating in one of them. INFORM is Nancy Heddle's study looking at, she's got 30, I think it's close to 32,000 actual inpatients that they're tabulating. A pretty circumspect database looking at the effect of younger versus older red cell storage. The enrollment is done. She's in analysis, and they expect to start writing their paper in April. ABC PICU is something that we're doing here. Again, hats off to our colleagues in Blood Bank, to my nurse coordinator, Dan Nierheim, and Shelley Pulkrabek, who are sitting in the back. We're doing ABC PICU here, which again is age of blood transfused to children in critical care units. The cells are either less than or equal to 7 days or 2 to 42 days. Again, looking at newer progressive mods. We started this a little over a year ago, and we're at 85% of our projected accrual at this point in time. Transfuse is ongoing in Australia and New Zealand, and then Cleveland Clinic is still running their own trial, looking at less than 13 versus greater than or equal to 21. So, in summary, there are now multiple randomized controlled trials looking at the red cell storage age. We didn't talk about them all, but there's one in neonates, now adult ICU, adult cardiac surgery, general medical surgical, almost 5,000 patients now that consistently show that there really isn't a difference between the shorter stored units and the longer stored units in terms of clinical outcomes, and they're definitely not beneficial if you receive shorter stored units and your patient outcome. And so this is a quote from Daryl Triulzi, who's in Pittsburgh, and it's compatible with what we're doing in our own institution. A change in red cell inventory management with preferential use of fresher cells in these populations is just not warranted right now. However, Simone gave this slide to me. She said, what these trials do not tell us, she's always the worrier, is whether the older or fresher stored red cells optimally increase tissue oxygenation. And I don't think we know the answer to that. Recap is going to help. And you guys probably all saw the JAMA paper where the folks from Mass General transfused children with malaria who had a fairly significant degree of anemia down to 3 to 5 and a severe lactic acidosis, 9, gave them young cells versus old cells and found both brought their hemoglobins up, both reduced their lactic acidosis, suggesting that both improved oxygen delivery. That hasn't been replicated by anybody else yet. It's brand new. It's very interesting to me as a pediatrician, and it's also a little bit kind of a head scratcher because in my hematology clinic I see little kids with hemoglobins that low, 3, 4, 5, who are profoundly iron deficient, who are riding a tricycle around my clinic waiting room. They don't have a lactate of 9, so there's probably something, as Claudia and I were just talking, something different about an acute anemia versus a chronic slow anemia and whether or not your red cells are going to help them if they're clinically inadequately delivering oxygen. Something that's ongoing is whether transfusion of the red cells stored 35 to 42 days, that late window, in and of itself causes adverse effects. Should that last increment of storage maybe be no longer standard of care? And so what we're doing is taking Nancy Heddle's study, ABLE, and RECESS, and combining them to look at, I'm not going to get used to this by the time we're done. I'm just not. Try to look at all the patients we had who were transfused with blood between day 35 and day 42 and try and do what they call an individualized patient analysis to see if we can find any signal at all. Because that's probably, again, the best opportunity folks are going to have without spending lots and lots and lots of money. And then there are these clinical populations that we haven't addressed, and do we need to Well, ABC PICU is ongoing. Trauma, just like I said up here, is acute blood loss versus chronic blood loss different in terms of what you need in terms of a red cell transfusion to improve your oxygenation. Maybe trauma is that acute blood loss population. Large volumes of blood. Megan Delaney out at Puget Sound is taking a look at the folks in recess who got large blood volumes to see if there's any signal there. There was no signal in ABLE that the less than 8 or more than 8 did any differently. Is sepsis different? There's dog studies that suggest it ought to be, but we've not done it in people. And then are the chronically transfused different? There may be something we can do with sickle cell patients, probably not here in the metro, but at other large sickle cell populations. So future research directions, plenty of stuff to still do. We've got ongoing studies which are still going to come out. We can do more analyses of all the randomized controlled data like we're doing the IPA for the 35 to 42. And then we have to think about whether or not there are still clinical trials that need to be done in populations that might still be different. This is Simone's slide. Just pick a bubble. Start with a bubble, go for it. And it will take persistence to maybe get to the bottom of this issue. Is shorter storage versus longer storage impact a clinically significant outcome difference? And again, I'm very honored and humbled to represent the work of all these hundreds of people and thousands of patients, and thanks for inviting me to chat.
Thank you. Does anyone have any questions?
Yes, sir.
I'll start out. In most emergency rooms now, all patients who are trauma patients and all patients who have massive transfusions are getting peripheral oxygen determinations pretty much on a consistent basis. That data should be available. Are you able to tap into that data?
Haven't done so, trying to do so. We've actually got a summit at the NIH in 6 to 8 weeks to talk about how to get at data we don't have and how to generate data we still need. Yep. Yeah, I just reviewed a grant trying to look at that too in a prospective fashion rather than a retrospective fashion. I think it's fascinating as to they could potentially be different.
Because from what I understand, a lot of the emergency room docs realize that the peripheral oxygen uptake is not necessarily what they would expect based on the clinical stories.
Right, exactly. That's exactly why and how we designed RECAP, because Matt Borgman, who's a military trauma guy who's out at Portland now, did something quick and dirty, just slapped on a Thenar Eminence STO2 sat monitor from HutchTech, and old stuff dropped the tissue saturation. That was the basis for how folks designed RECAP. So hopefully that will come out, hopefully that will be published soon. Yep. I think the other thing that I want to advertise is one of the things that I think this network did really, really well was foster and promote and put forward the younger folks in the transfusion medicine groups, the hematology groups, the ancillary groups. A lot of the manuscripts that you'll see coming out of this study are from folks that are a little bit more junior in their careers, and the idea is, as Jeff mentored me and Nigel Key mentored me, is to not make them deaf, is to spread the wealth, benefit others, and mentor so that the next generation's ready to go, hit the ground running. Yes, sir.
One of your earlier slides showed the changes at the cellular level in red blood cells and their capacity to perform their function. The studies you mentioned were on the clinical side, but at the cellular side, do we know that the changes in red blood cell function really significantly change between 10 days and 24 days? If there are changes at the cellular level that are not translated to clinically significant,
There's the crux.
then
Yeah.
there is something missing
Yes.
here. But if
Yeah.
there are no changes at the cellular level,
Right.
then there would be no surprise that the
Correct. Correct. There are many, many, many people who have spent their lifetimes and their careers investigating the storage lesion. The fact that there are biochemical changes, 2,3-DP drops immediately, cell morphology changes very quickly, changes in the supernatant in the bag very quickly. People are doing very sophisticated studies relative to nitric oxide onloading and offloading, changes in red cell membrane relative to that ability, all kinds of stuff. But for some reason it just is, unless we're not looking at the right parameters, it just is not translating to a change in the clinical outcome. And that's why we picked the outcome measure we did for the cardiac medicine study, is we figured following on the heels of the Cleveland Clinic retrospective, we were going to get one shot at showing old versus new, beneficial or not beneficial, no difference. And so that's why we picked, look at all the organ systems, pick the worst score in that week, add them all up, and is there a difference? And we couldn't find anything. It may be we find that 35 to 42 day window is different, but you know, there are limits to what we can do with what we have now. The lab my daughter used to work in found changes in the cells by Raman spec within the day of selection of pheresis, donation. Found a change in donated blood within the day. So there are changes that start almost immediately, and I'm amazed that we can even take it out, plop it in a bag, and give it back and have it do anything except expand volume. So maybe there are features, but there are features that we either haven't identified or things that some of these more sophisticated studies on that bubble diagram are going to be able to address. It may be individual components and individual recipient interactions that may make some people do better, worse, or no different than others, but there's still a lot of work left to be done.
Any other questions? Thank you.
Thanks very much.